So once we have decided that what all has to be done for starting a phakic IOL practice, the next thing is selecting which phakic IOL you're going to go for. Given times, we have so many phakic IOLs in the market, and to speak upon this, we have Dr. RIDHIMA BHAGALI, who's going to speak about selecting the different phakic IOLs.
Good morning, everyone. Thank you very much, Mukesh, for this introduction. So I'm going to discuss the various phakic IOLs that are available in the market, and I'm going to talk about the features of each one of them. So I think I'll start off with, I have no financial interests with any of these companies that I'm going to discuss with you. There are three types of phakic IOLs, just like Dr. Karishma had mentioned in her previous talk. The first kind are the angle-supported or the anterior chamber phakic IOLs. The second, the iris-fixated phakic IOLs. And in India, the popular ones are the sulcus-supported phakic IOLs. The angle-supported ones are now withdrawn from the market, and the main reason behind that is the endothelial cell loss that these lenses led to. Also, a toric version was not available with these, and I have personally used the Acrysoft Cachet. I've also explanted a few that had resulted in cataract. This is just an image. However, they are no longer in use in any part of the world. However, the iris fixated ones are quite popular in a lot of European countries. In the UK, they are the phakic intraocular implant of choice when they are going for a phakic IOL. This is an FDA approved Verisi phakic IOL, commonly called the artisan lens in Europe. It is a rigid PMMA lens it's an iris claw lens, and it's available to correct myopia from -3 to up to -23 diopters. Also, a toric version is available and a hyperopic version. A foldable version of the same, the VeriFlex, is also a popular implant. It has a polysiloxane optic with PMMA haptics, and this is the foldable version of the same artisan lens. However, the lenses that are more popular in our country are the sulcus-supported phakic IOLs, and we have quite a few, but the most popular is the Evo Vision ICL from Star. This is a single-piece plate haptic lens. It's foldable, and it's made up of a biocompatible material called Collamer, which stands for, it's a collagen and hema copolymer. It's a very thin lens, and it's placed in the sulcus. It sits behind the iris. So the advantages are that it's closer to the nodal point of the eye. It has better cosmesis. It's far away from the cornea, so the endothelial cell loss is much lesser as compared to the other lenses. This would be my lens of preference wherever I have to choose a phakic IOL implant, because they've been the pioneers and the market leaders of phakic intraocular lenses. Their material of the lens is patented, and it's a very soft, pliable lens. So in this video, I'm just showing you, for any reason, if you need to explant the phakic intraocular lens, and you may need to do it if there's a sizing issue, a refractive surprise, if it leads to a cataract later on, in cases of, like, I have explanted, I think, at least 3 of them, and with an ICL, it's such a soft, pliable lens that you can see in this video just a gentle, consistent pull, and the lens would fold upon itself and easily slide out of the eye. So this is with regards to the material and ease of explanting it. Yeah, it's not like, I've not edited the video, so and it would fold upon itself and come out through the same, like, 3mm wound, versus another phakic intraocular lens. The materials are different, and they are not going to fold upon themselves if you need to explant them. So here you can see the wound is being slightly enlarged, and the lens would come out without cutting it. You can still get it out, but not through the same 2.8mm wound, okay? So, and I'm also happy with the customer support. If you have errors with a refractive surprise, you need an IOL exchange for some reason, you would get really good support from the company. So the ICL was the V4 model, is the first one. When I started using it, it came in sodium chloride solution, and it was available in 5 sizes from 11 to 13mm. And with the sodium chloride version, we usually used to wait because it would hydrate in the eye and the size of the lens would increase. So we would wait to measure the vault and then judge the sizing and place an order for the other eye lens after that. However, from the V4 to the V4B version, version and V4C, they are now available in BSS, that's the balanced salt solution, and they come in a hydrated form. So the size, the power of the lens remains unchanged in the eye compared to what you get it as. The current one, the Vision ICL V4C, is the popular version now that comes with a central hole called the aqua port and Centraflow technology. That means that the aqueous has a more natural flow through the lens, and that helps in nutrition of your natural lens. You can do away with iridotomies if you have the courage to avoid them entirely. Also, it helps in reducing the incidence of an anterior subcapsular cataract. It helps in better visco removal at the time of surgery. So the design of the aquaport, it's a 360 micron, a tiny hole at the center of the optic of the lens. And as I said before, there are also 2 tiny perioptic holes as well to facilitate removal of visco. The size of the port, how did they come up with 360 microns? If the size of the hole is too large, that could interfere with the visual optical quality of the patient post-operatively and also result in more glares and halos. Versus a very small port would then have a risk of getting occluded and a rise in intraocular pressure. Also, a potential for streaming. It's a very small port. There would be a jet of aqueous hitting the corneal endothelium and could cause an endothelial cell loss. So the current size of port, the results have shown that the optical quality, if you compare it, the modulation transfer function versus a regular V4B ICL is unchanged. And the results for quality are more or less comparable. So the Vision ICL is available to correct myopia from -0.5 diopter is the power of the lens up to -18, and a toric version is available up to 6 diopters of astigmatism, while the hyperopic lenses are available from up to 10 diopters with a 6 diopter cylindrical power. This is the optic size or the optic zone diameter for the ICLs, starting from 5.8 millimeter optic size for up to a -9 diopter, and the size of the optic goes on reducing as the power of the lens increases. However, the current, as you may have heard, EVO stands for Evolution in Visual Freedom. And EVO lenses, the concept has been enlarging the size of the optic zone of the ICL. So the optic diameter now is almost 20% higher than the V4C model, and that is to do with the pupil size in mesopic conditions. Studies have shown that in youngsters between 20 to 40 years of age, the pupil size is at least 5.2 to 5.4 millimeters for night driving or reading in low light. And so if the pupils are large in low light conditions, the potential for optical phenomena like glare, higher order aberrations, halos is more. And hence the optical diameter of the ICL has been increased to I'll show you the table, but up to 14 diopters of power, the optic size zone has been increased, and these have been labeled as the EVO Plus lenses, whereas from 14.5 to 18, they're the original diameter, and they are now called the EVO lenses. So in vitro studies have not shown a dramatic change in the higher order aberrations that have been measured between the EVO and the EVO Plus lenses. However, they are thought to definitely benefit people with larger pupillary diameters. So if the original V4C model had a 5.8 optic diameter, now it comes as a 6.1 diameter. So this is just a video to show the loading of an ICL. It comes in a BSS glass bottle, and it comes with a special cotton tip applicator, which is used to pick up the ICL. Placed in the cartridge, there's a special forceps that holds the lens, and it's hence loaded. The surgical steps as seen here, like after side ports and an HPMC viscoelastic, a 3.2 mm wound is done. The lens is always loaded as an inverse taco, and this is a slow implantation to demonstrate the implantation and tucking in of the haptics. I think Dr. Mukesh in his subsequent talk is going to elaborate more on these surgical steps and tips and tricks so that to make it a little easier for you. But this is just to demonstrate the loading of the ICL versus the other lenses that I'm going to discuss further. There are a lot of situations wherein as I said, it's available only up to -18 diopters. So what if the refractive error of your patient is -20 two, as is seen over here, I think 22 and 24. Or also I had this case with mixed astigmatism, and I actually have a refractive center where I do quite a bit of corneal lasers and SMILE, but mixed astigmatism is definitely one of the categories where I will tell the patient that you will have a residual error, you may have regression, you may need retreatments. With retreatments, there's risk of epithelial ingrowth. So I have done this many times with femto-LASIK, and for this particular case, the PHAKIC was also about 480, and I thought, let's go ahead with a phakic IOL. That would be a better option than corneal laser. I did the calculation for the STAR ICL. It showed that it would leave about a 1.25 residual SIL in both eyes with a 6 diopter cylinder. However, when I contacted the company, these lenses were not available. They said they would take at least 3 months to manufacture them, and there would be with the lenses they had available, there was almost a 2+ cylinder remaining. So then my next best option was the IPCL from the Care Group, because they do make custom ordered lenses for different powers, different sizes, and they had a 7.5 cylindrical power available with them. I got the lens in about 6 weeks' time. So the IPCL is what I'm going to discuss next. It's been available since 2014, and the version 2 with the central hole was launched in 2017. It's available in 40 countries, not just in India, and it's quite commonly used in other parts of the world as well. It comes with a central hole, and it has these optic margin holes. So these have to be always oriented superiorly when you implant the lens. They also have these haptic margin holes to ease in the tucking in of the lens. They have, instead of just 4 haptics, they have 6 points of contact for better stability in the sulcus. They also have these notches to help with the orientation of the lens. It's available in more extended range of sizes from 11 to 14 millimeters, and the regular lenses come up to 22 diopters of myopia, with 6 diopters of hyperopia, but there is a custom diopter range which is quite great, because you'll commonly get patients who have more than 20 diopters, and up to 15 diopters of hyperopia is also available. So the central hole of this lens is slightly different in design. It's conical in shape versus the regular hole of the ICL, and it's thought, the company says that is to reduce the incidence of light scattering in photopic as well as mesopic conditions. The light scattered and lost is both lesser with this kind of design of the hole. Also, these haptics have a spring effect with the intention that even if you're a little 0.25 millimeters off in the measurement of the white to white on either side, it would not result in that much of a difference in the vault. So they're less white to white. Design is dependent less on the white to white measurements compared to the ICL. Also, there's a universal alignment. That means it's always has to be oriented at 0 to 180 degrees. There's no need to rotate an IPCL at all. So this is usually the alignment of the IPCL. And this notch here has to be on the right side. As you're looking at it, in the right eye as well as the left eye, this is the notch right here. And these are the optic edge holes that always have to be oriented superiorly. There is also a press biopic version in 5 sizes that the IPCL comes in. This is another patient where I preferred to use the IPCL. The white to white was about 10.7 millimeters, and with the ACD is about 2.88. So at least the ACD should be about ideally 3 millimeters. Was the borderline reading would be about 2.8 millimeters. So it's a small ACD, small white to white. So it's a small anterior chamber. And I did not want to go ahead with a 12.1 size. The ICL is available in these 4 sizes. A 12.1 millimeter ICL I thought would be quite big. So the IPCL gave me the option of an 11.5 or an 11.7 millimeter lens. And still the post-op vault is about 600 micron. So you need to be vigilant and choose what lens you want to go ahead with, not just based on what the patient is willing to pay you, but also based on, keep a look at what you would end up with. So this is just a quick video to show you the loading of the IPCL. So this is the toric version. Marking is done just 0-180 for all cases, and the initial steps are similar. Instead of a 3.2 or 2.8 millimeter clear corneal temporal incision, and the loading is similar to an IOL. HPMC in the cartridge, I'm just tucking in the edges of the lens, and instead of a reverse taco here, I'm loading it as a taco, like a regular IOL. And that's the lens going in. This is the left eye, so you can see that the edge holes are superiorly. So when you load, they have to be direct oriented on the right side for the left eye. And then tucking it in and removal of the viscoelastic. Another biotech phakic IOL is also a good lens. It is a hydrophilic acrylic material with a central hole, available with up to -23 diopters, and comes in 3 sizes. It again has easy loading, good results. The injecting is a little tight, but it's a good injector system. The results are also very good. The toric version is also available, and I've used these also quite a bit. Again, I'm just showing you the same. Just the orientation marks you need to be aware of. They are different for each lens. Like for the biotech lens, the orientation marks would be for the left leading haptic and the right trailing haptic. Again, this is their side ports being made, intraocular, preservative-free lignocaine, viscoelastic, a 2.8 mm clear corneal incision. Loading of the lens is quite similar to our regular intraocular lenses, but just that you have to be, and you need to ensure that it is convex side up. And again, I'm loading it like a regular IOL, like a taco. Just ensure that the edges are in. Press down the lens and gently, gradually injecting it into the anterior chamber, ensuring that the mark is on the leading left haptic and it's opening, unfolding the right way. Visco over the lens and tucking in the haptics. So I'm not going into the surgical part of it. And the last lens that we have available with us is the Appasamy RIL. It's available in similar dioptric ranges and sizes. It doesn't have a central hole as of now, and so I do not use it that commonly. Again, these are there's a right trailing, there's the marks are reverse on this. If you compare it with the biotech, there's a mark on the right leading and the left trailing haptic. However, the injecting system and the implantation techniques, every anterior segment surgeon would be familiar with it. So you can see the orientation mark right there. So to summarize, I would say the results, you need to base your choice of lens on the outcomes and the results of your phakic intraocular lens, your comfort and convenience of using, loading, injecting, and ordering your lens. For the STAR ICL, you need to be trained and certified for them to allow you ordering of their lenses and use of their lenses. I would always prefer one with a central hole. I personally do not do an iridotomy anymore, but I know a lot of surgeons still prefer to do it. Another determining factor could be the affordability of the patient, but sometimes you also need to base your choice on the range of powers and sizes that are available and provided to you. So thank you very much for your kind attention. If you have any questions, I would be happy to take them.